we have the topic which has been given to me is different therapies, cancer treatment therapies across the globe. And I have the privilege to have a very illustrious panel with me. And we have Dr. Dinesh MG, who is a very senior HOD and senior surgical oncologist from Altius Hospital, Bangalore. Welcome you, sir. And I have Dr. Mandeep Singh, and I've worked with him. He's the HOD and Director of Surgical Oncology, CK Birla Hospital, Gurugram. So it's a privilege to see him again. And at the same time, I have Dr. Rajat, who is a very dear friend. He's a medical oncologist working at Fortis Hospital, Noida. So let's proceed further. So I would just want to understand from Dr. Dinesh. Dr. Dinesh, we are talking about very hi-fi things today, and we are talking about different therapies. But I just want to have a basic question, like, why do we think that at this point of time, even after so many years of treatments and so much advancements in oncology, we have not been able to control tobacco, which is the main cause of cancer death? And 30% of cancers, they are caused by tobacco. 80% of lung cancer deaths happen due to tobacco. So what do you think is the basic reason? And in the meantime, if someone can tell me, the slides have...
See, speaking about tobacco, hi, I'm Dr. Dinesh. I'm a surgical oncologist from Bangalore, working in Altius Hospital. Speaking about tobacco, I think past 2-3 days I've been speaking about tobacco because it was a no tobacco day yesterday, 31st May. And we know that this gutka is banned. In Karnataka, it is banned since 2013. But still, people get all the ingredients, they try to mix it, and they form their own gutka. And some packed gutkas also they are selling without any advertisement. They are doing it. So I don't think so. They're strict about this gutka ban. So we see a lot of oral cancer cases here, especially in northern Karnataka. We see a lot of oral cancer cases, and that too they are all not so affordable. According to me, for tobacco, I don't think so. We are strict about this ban and banning of gutka, and also the smoking in public places is not banned. I think they are not so very strict in Bangalore, at least.
So we have such strict regulations for drug abuse. We all heard about Shah Rukh Khan's sons also. And in spite of that, tobacco and alcohol, there is not much ban on this. So we have people from business world. And so I would really request you people to put an emphasis, because whatever we might say, we might step up the ladder, do robotic surgeries and whatever. But if we are not able to curb the basic problem, the root cause of the problem, I think whatever advancements we may do, we will not succeed. Has someone shared my slides, please? Coming to Dr. Mandeep. Dr. Mandeep, again, a very basic question that I'm coming to, because we are talking about hits and misses. So I think in my 25 years of practice, I've been facing this issue every day of telling the patients to get a biopsy done. But that's a very big problem. Even people from very educated families, they come to us and they say, कुछ भी करा लेंगे, biopsy नहीं कराएंगे. कुछ भी करा लेंगे, आप डॉक्टर साहब बिना उसके ट्रीटमेंट चालू कर दो. Although we know it's an era of personalized medicine, but how often do you come across this situation? And do you think we can do something concrete? This is the biggest miss I feel in development of oncology services. So what is your take on that?
Thank you, Dr. Indu, and I really agree. 200 times I agree with this with you on that there's a big myth around the concept that biopsy कराई चीरा लगाया तो बढ़ जाएगा. मतलब एक इतना ज्यादा एक पूरा myth इसके अराउंड बना हुआ है कि चीरा नहीं लगवाना है, और चीरा नहीं लगवाएंगे और तब तक वो डायग्नोसिस नहीं होगा. तो especially Dr. Dinesh was talking about oral cancer, and North India also is more or less the same as South India about the incidence of oral cancer. So we also see a lot of oral cancers, breast cancers, everywhere. The concept is that you do anything, you diagnose it without a biopsy. And because of this very reason, that we don't want to get a biopsy या चीरा नहीं लगवाना, the cancer actually, when it is a smaller cancer, they would not get a biopsy done. A small lesion, they would not get a biopsy done, and that is not diagnosed. And then when it comes to advanced stages, at that point of time, obviously we are getting all the investigations from a biopsy to PET CT. And again, through you and business world, I would really request that this myth of not getting a biopsy done and biopsy से cancer बढ़ जाता है, वो एक बहुत ही बड़ी myth है. इसको please आप address करो. If I do a biopsy, I don't treat, definitely cancer will increase. The problem is that whatever has happened is that people get a biopsy done, the cancer is diagnosed, and majority of time the cancer is being diagnosed at advanced stages, and obviously the patient then succumbs to the disease, and everything is attributed towards the biopsy. इसने biopsy कराई थी इसलिए उनकी death हो गई. अगर biopsy नहीं कराई होती तो शायद वो कुछ नहीं होता. So please, we have to address this.
So Dr. Dinesh, you must also be coming across this situation. So is there any particular situation when you proceed with surgery, even without a diagnosis? And or if we proceed directly with surgery, so suppose so many patients come to us with a breast lump, where we get where the patients get an excision biopsy done straight away rather than getting a true cut biopsy, ultrasound guided true cut biopsy, and then they have to undergo a repeat surgery because of the first incomplete surgery first time. Or so many times we come across females who have undergone a hysterectomy straight away on an ultrasound report which showed a fibroid and it turns out to be malignant. And then patients, they have to undergo a repeat surgery, or it's an incomplete surgery. Sometimes we have to offer radiation as well. So how many times do you come across this situation where people have been, because fortunately we are sitting in big corporate hospitals where things are systematic, but most of the patients are being treated at smaller centers or in standalone clinics or in small nursing homes, and we come across such patients. So is there any message which you want to give to the audience who is here for the benefit of the patients, please?
Yes, like you told, I think first we should educate our own colleagues, not oncologists, I'm telling, the others who are any GPs, any other surgeons. So I think instead of doing surgery directly for any breast lump, it's better they do some true cut biopsy, or they send them to an oncologist who does the true cut, and if they can send them back, if it is benign, obviously we would send them back. So most of even I don't know, I'm not blaming any other doctor, any surgeon. So many times we do get cases where hysterectomies have been done, and that's when they come to know that it is CA cervix or CA endometrium, something like that. Or many times it is the ovarian cyst where they rupture and they send. So all these cases we have seen, but like you told, sitting in corporate, we get such cases only. So I don't know how do we educate our colleagues, that I think we should address.
So we talked about some basic problems, but there is some good news also along the way, because over the years, what we have seen is that since 1991, there is a 29% decline in death rate, which is a good news. 150 plus new drugs have been introduced for treating cancer since 2006. And as per one data, ASCO 2020, 2.9 plus million deaths have been averted in US. We don't have the Indian data, but this is a this is a thing to smile about. And this is because a lot of developments are happening, not just on prevention of cancers. We had a very elaborate presentation from Dr. Das just a few minutes back. We are diagnosing cancers early. Now we are seeing many patients with CA prostate who are coming to us and in stage 1, and we are able to treat them very nicely. The advancements have happened not just in the field of radiation oncology, medical oncology, surgical oncology, but in molecular oncology field as well. So we are able to cure many patients, and in fact, what we can say now is that 2 out of 3 people are able to live for 5 years, which is a very good news. And because of all these advancements, we are able to now give a very good quality of life to our patients. And I don't know why we don't have a radiation oncologist in the panel, because we know that I think I'll have to do the job myself. So 50% patients are cured by surgery. 40% patients are cured by radiation alone or combined with surgery and chemotherapy, and 10% by chemotherapy alone. But of course, this figure goes very much high if we combine radiation and surgery. I think Dr. Rajat is not able to join in. Someone will have to let him in. I think he has joined now. So next slide, please. Welcome, Dr. Rajat, to the panel. Next slide, please.
Yes, now I am there. Yes.
So thanks. So I was just talking about tobacco-controlled cancers, and we know that this is the most preventable cause of cancer. It causes cancer of 18 body sites, and in spite of that, we are just struggling. This is the biggest miss, I think, in field of oncology. Next slide, please. So we all know that cancer is a hungry, money-seeking disease. So we have to use all these modalities, radiation, surgery, and chemotherapy. And we have seen very, very beautiful advancements in the field of radiation. When I was doing my MD way back in 1996, at that time, we used to do 2D radiation planning, but now we have moved to three-dimensional conformal, IMRT, IGRT. And in fact, now we are able to treat left-sided breast cancers with deep inspiration breath hold technique. So which leads to very much decreased doses to the lung and heart. And we have stereotactic body radiotherapy for lung tumors, liver tumors, for adrenal mets, for brain metastasis. We are doing SRS. And of course, we do brachytherapy. And Dr. Huko was talking about flash radiation, which is the most in thing or the new kid on the block. So, but the problem is that all these techniques are not available all across India. So some smaller centers, they don't have just cobalt machines, and we are not able to treat these patients with the best technologies. Similarly, we have moved from simple biopsy to open surgery, to laparoscopic surgeries, and to robotic surgeries. We will talk about that. And chemotherapy, Dr. Rajat is here. He would agree with me that we have oral pills, we have hormonal treatments, we have chemotherapy, targeted therapy, immunotherapy, and cancer vaccines. Next slide, please. But the problem is that we don't have an equitable distribution of these services. So, Dr. Rajat, I would like to understand from you, do you think we have equitable provision of personalized cancer care for everyone? Do you think we have reached that stage after 50 years of independence?
So if we talk about personalized cancer care is a very new concept in medical oncology, and it is still evolving. It has come up in the last 3 to 4 years only, and we have certain tests available that we are doing for individual patients, which tell us as to which treatment modality should be used, and they guide us about the treatment. But then if you talk about the cancer care in general, even that is not available to the masses or to each and every part of our country as of now. I was listening to your discussion about the cessation of tobacco, and the other panelists seem to agree that also we've not been able to really hit the root cause. And same is the case with the cancer care which is there. So it is not available to everybody, and the quality of cancer care is certainly not available to everybody. So this is something that we really have to look at and work towards it. Personalized cancer care, even in the metros, even in the big cities, is something which is still evolving, and the cost remains an issue because the tests which are done for personalized cancer care are expensive, and not everybody is able to really do those. So certainly bringing the cost down, making the clinicians more aware are really two stems that will help us in bringing more and more personalized cancer care to each and every patient.
Very rightly said. Smriti, I can't see the slides again. Yeah. So if you see this slide, we sometimes we say that cancer doesn't discriminate, but I think cancer does not affect all people equally. There are a lot of cancer disparities all across the globe. So all the patients, we have different treatments for children. They don't get the right treatment at so many times. Female sex, LGBT, we don't have any specific treatments for them. People with minor minorities and African Americans, we see they are not included in the clinical trials. Poor people, they cannot afford the treatment, or they're staying so far from the cities that they're not able to get the proper treatment that they should be getting. There is this huge population of adolescent and young adults. In fact, there is a new branch which is coming up, that is tired. We don't have proper recruitment of people from these groups in the clinical trials. Similarly, geriatric population, we don't even know what is an exact geriatric population. Does it more than 60 years of age? Is it more than 65? Is it more than 70? And these are not equally representative in the clinical trials. The technology is not available everywhere. We don't have emotional and psychological support. This is a very big disparity. In spite of, I'm sitting in Narayana hospital, we don't have a psycho counselor available every day to counsel the patients. Patients don't have access to clinical trials, and more so these numbers have gone down after the COVID. And as I said, we have so many international patients who are coming to treatment for us just because they don't have good treatment facilities in their own country. So we have to move the needle in cancer care for less privilege. Next slide, please. So I would just like to show you, next slide, please. So these are the distribution of radiation machines across India. This is a paper which was presented in 2019. And if we can see from here, that North, it represents 24% of the population. And we have 85 linacs in North, and in South, we have 190. But if you see in Central India, there is just 12, or in the Northeast, we have only 6 radiation machines. So how do we treat these patients well? This is very, very difficult. If we see about CyberKnife, we have 3 machines in North, we have 4 machines in South, and we have no machines in Central, East, or Northeast, or Western part of the world. So this is when we have, if we see, so South is comparatively better placed in terms of access to good radiation facilities. Next slide, please. And although a number of new centers are opening up, but if we still see, we still have a shortage of close to 4,550 radiation machines in India. And I'm not talking about brachytherapy machines. The ideally required for whole country is 1,250. And we have only 250 brachytherapy machines all across India. We have shortage of 1,000 machines. So this is what we are talking about after 50 years. And this is the disparity. These are the misses in radiation treatment all across the globe, all across India. Next slide, please. So what are the hits and misses of radiation? I had to make this slide because I don't have any radiation oncologists in the panel. So hits, I would say, is development of IMRT, IGRT, deep inspiratory breath hold, stereotactic body radiotherapy, stereotactic radiosurgery. And I think a very, very good advancement has been the development of hypofractionation, because of which even the patients with prostate cancer early stage, they're able to complete treatment in just 5 sittings. Early lung cancer, we are able to treat in just 5 sittings. Now we have MRI guided linacs. So the soft tissue delineation is much better. We are able to treat the patients much better. And recently Reflection 11 machine has been installed, not in India, but with which we can do PET based radiation planning. So these are the hits, but things which could not stand the test of time are accelerated fractionation and hyperfractionation. We are talking about protons. We don't know exactly what would be the results in long term, and carbon ions, we don't know. Dr. Dinesh, what is your take on protons? This is the most advanced radiation technology. Do you ever send any patients to protons? We have Dr. D. Cruz, who has also joined here, who does a lot of head and neck work. So Dr. Dinesh, your viewpoint on protons and these latest radiation technologies. Do you think they are hits or do you think they are misses?
Proton, we have not recommended anybody from our hospital as such now. Anyway, it's only in Chennai now. And it is, once we recommend, it's quite expensive. And I don't think so. 1 or 2 patients, they were not willing to go there to Chennai. One thing is they have to travel there, and it's quite expensive. So I don't think so. Proton, we have not yet sent any patient as such now.
Now coming to, I feel, is this the golden era of cancer treatment? Because we know that every tumor has a unique signature and personalized therapies are crafted for each patient. Next slide, please. So as per 2010 data, 12 new drugs were approved by FDA. 348 phase 3 oncology trials were ongoing, 861 cancer drugs in trials, 2,000 plus clinical trials which were accepting children and young adults, 200 plus prevention trials, and 100 plus screening trials. Next slide, please. So are there a lot of missile drugs or molecular tsunamis of site-specific cancers? Dr. Rajat, next slide, please. I want to ask you one question. So, Dr. Rajat, I know I'm asking a very controversial question, but I think all of us need this answer. So, are these really personalized therapies or precision medicine or targeted therapies just fashionable and lucrative, or do you think they really work? Do these postpone death sentence for a few months of remission, or do you really feel that we should go more and more for immunotherapies or targeted therapies, and they'll make a big difference in the lives of cancer patients, and we will be able to not just extend their life by years, but also improve their quality of life? And because these are very expensive drugs, we just talked about proton treatment and 30 lakhs per treatment. So, what is your take on these personalized therapies or immunotherapies? Yeah.
Yes. So when I say personalized therapies, I don't really limit myself to immunotherapies, but there are many targeted therapies also which are there, which I would like to include in the answer that I'll give to this question. So I certainly believe and I strongly feel this, and I do that in my daily practice in my OPD also, that I tell my patients that these medicines, they generally work better than chemotherapies, and this is supported by evidence as well as my experience. The response rates are definitely better because you have chosen these therapies after checking the genetic makeup of that particular patient by taking that sample and doing that somatic mutation testing. The evidence says that most of these therapies have been approved by either an improvement in the progression-free survival, or if we are lucky enough, the improvement in overall survival as well. But then, yes, at the end of the day, the clinical trial will never tell you that this is the particular cost. The cost is definitely huge for some therapies. The cost is a little moderate for many of them, and the cost is quite less for some of them. Now, this cost is definitely a, a relative issue for many patients. So, there will be people who will be able to afford it. There will be people who will not be able to afford it at all, and people who will be able to probably afford it, but with some difficulty. So the cost benefit ratio is something that I really discuss in detail with all my patients. And the cost not only for the next 2 months, 3 months, or 5 months, but they should know that these medicines, because most of them are used in a stage 4 disease, will continue for quite some time. So they have to really weigh their pocket in terms of the monthly cost multiplied by what is the approximate months or the years this medicine is going to work for them. Now, when they take the cost benefit ratio into their mind and they really weigh it, only then I tell them to start these medications. So we have many medicines which have come up in the last decade or so, and some of them have actually been very wonderful. There is no doubt about it. I can give some examples. There was a time when hormone therapy in breast cancer used to be the way to go for a stage 4 hormone receptor positive disease. And before that, chemotherapy used to be given. Then came tamoxifen. Tamoxifen just had a PFS of 8 to 9 months. Now we are looking at CDK4/6 inhibitors, which give us a PFS and a very good quality of life, mind you, very good quality of life for approximate duration of say about 24 months. So we had 9 months on one hand and 24 months on the other hand is a huge difference with a good quality of life. And of course, I would like certainly to have the cost down a bit, maybe 50% of what it is right now. And time is going to come. So when you said that it is a golden era for cancer treatment, I would say certainly yes, because we have certain medications, and it is going to be some time later going to be these medications coming into the ambit of many patients. For example, palbociclib, the patent is going to expire in another 3-4 months. The cost will be around 15,000-20,000 a month, which is much less than chemotherapy as well, and much more beneficial than chemotherapy. Another example, lung cancer. I'm sure you know very well that how things have changed in the last decade or so, with the overall survival just being 9 to 10 months, and now overall survival we are looking at 4 years. So certainly they so-called fashionable or lucrative they may look, but certainly they work. But yes, not for everybody. cost benefit ratio has to be seen. And of course, as a medical oncologist, one would feel that yes, cost should come down, but maybe it cannot happen overnight, but over a period of time this will certainly happen. And once the cost come down even more, this cost benefit ratio, which looks a little skewed at times, will become better, and we'll be able to benefit more and more patients.
Very, very nicely put, Dr. Rajat. I think you nailed it. So I think Gleevec is a very good example. Molecular drugs, imatinib, which really worked well, and it changed how the way we treat CML these days. And in fact, immunotherapy drugs for melanoma, they have done wonders. They are now being used in renal cell carcinomas for patients with sunitinib. Like earlier, every patient with surgery would go for nephrectomy first, but now we are able to debulk the disease by giving sunitinib or things like that. And immunotherapy, they are really working well. So we have to choose the patient well. Certain times, combination of drugs, combination of immunotherapy may not work, but we have to see what is working on the patient and what is not working. And it has to be a very, very detailed discussion with the patient so that we are able to improve the quality of life of the patient and extend their life as well. Next slide, please. Next slide, please. Now coming to Dr. Mandeep. Dr. Mandeep, we are here. This is the era of robotic surgeries, and this is the era of robotic surgeries. So next slide, please. So we have come a long way from radical mastectomies or extended mastectomies where the whole of the breast would be chopped. And now we have come up to an era where we are doing only breast conservation surgeries, or we are doing sentinel lymph node biopsies, or we are doing for laryngeal preservation, we are giving chemotherapy. So nowadays surgery is changing, and with the appropriate use of radiation and appropriate use of neoadjuvant chemotherapy, we are able to improve the survivals of the patients. We are able to preserve the voice. So organ preservation has come a long way, not just for laryngeal cancers, but for bladder cancers and even for rectal cancers. Now we are coming for wait and watch policy for certain number of patients. So I think these are some of the hits which have come up in the field of surgical oncology, which have made the lives of people better. So we talked about this initially, that the biggest miss ever in oncology was, can a biopsy make my cancer spread? And if you Google it, you will get these many results for just this question. Next slide, please. So Dr. Mandeep, according to me, these are some of the hits like MRM to BCS, sentinel lymph node biopsy, oncoplasty, organ preservation by NACT, and I think total mesorectal excision for rectal cancer is a game changer in rectal surgery. D2 dissection for stomach cancers, use of indocyanine dyes, robotic surgery for prostatic and gynecological cancers. So Dr. Mandeep, you do a lot of oncoplasties, and you are an expert in head and neck cancers and other cancers. So according to you, what are the biggest hits and what are the misses in the field of surgical oncology? What is your take on that?
Yeah, Dr. Indu, it's a very appropriate thing that you have raised. So surgery over the time, like last 50 years of our journey in cancer treatment, definitely it has become, I would say, it has become more. There are aspects which it has become more radical also, and there are certain aspects which it has become more appropriate or less intensive also, where morbidity is less, mutilation is less. Specifically, when I come to breast surgery, so in appropriate cases, early stage breast cancer, those patients who have a very good response to neoadjuvant therapy, so these patients are now amenable to breast conservations. Those without any lymph nodal mets or early breast cancer are now amenable to sentinel lymph node biopsies and all. So definitely we have decreased the mutilation, and more than that, now the research is there which says that those patients, like there was a recent paper which was last in 2018 in San Antonio, it was presented that those patients who had underwent breast conservation, early stage breast cancer, they tend to live longer. Obviously, radiation has played a role in that, but yes, when we say a breast conservation at an early stage, we do include surgery with radiation. So even the survival is better, the quality of life is better, the organ preservation is better, and obviously the female body habitus is preserved. Whereas if I look into the other aspects of surgery, like HIPEC has come into a picture, in which obviously with more radical intent and peritoneal malignancies which are not amenable to chemotherapy and all. So with HIPEC, definitely the survivalist benefit has improved. Secondly, even for if I say head and neck cancers, so yes, TOS for early oral cancer is a very good option, and TOS for advanced oropharyngeal cancers is definitely not a good option. So there's no debate upon that. But yes, selective patients, selective for specifically those patients in which early oropharyngeal cancers are there, TOS can be considered. So yes, like if you have a early prostate, early oropharynx, so it is a robotic surgery versus radiation, and both of them have their own benefits and own other aspects also. So yes, that can be selected by the patient and the treating doctor, and both of them are equally good. But if I also look into other stages of head and neck cancer, like even now with intent of ITF clearance, advanced salvage resections, so we are now able to have a better survival in advanced oral cancers, in post CTRT, laryngopharyngeal cancers. So all these aspects have also included. And yes, the surgery over the time in selected cases has become less morbid. Surgery over the time, as we have grown in our experience and our learning curve has also become better, so we have become more radical, where survival is much better. And other aspects like TME, D2 dissection, definitely it has. So what it is there? Okay, appropriate surgery for appropriate stage of disease.
So I think that's a very important point raised here, that the importance of tumor boards. I think it comes there because now we are having more number of patients who are being diagnosed earlier, and even patients with metastatic disease, they are living longer. Earlier, we would never see patients with metastatic disease surviving more than say 8 to 9 months, but now we have patients living metastatic CA breast cancer surviving for 5 years, 7 years, even with lung mets, bone mets, or small soft tissue diseases. And there's this concept of oligometastasis, where you treat the patients with a more radical intent rather than a patient with a polymetastatic disease. And because of the combination of immunotherapy, because of the combination of neoadjuvant and appropriate sequencing of treatments, now we are able to do more radical surgeries, but which have become much better. And at the same time, we are able to preserve the organ function, which is a very important aspect, and the quality of life we are able to maintain with these patients. Like for pancreatic cancers, if we talk about earlier, the first step would be surgery, but now we are incorporating more of, say, FOLFIRINOX combination before radiation, before surgery, or in fact, adding a little bit of SBRT, FOLFIRINOX plus radiation, to make the tumor resectable. So the patients who were not operable earlier are now getting more operable. Similarly, for patients, say, as we talked about renal cell carcinoma, with incorporation of sunitinib and immunotherapy, now we are able to do more nephrectomies. For patients with brain metastasis, we are able to do hippocampal sparing, we are able to preserve their memory, we are able to preserve scalp sparing treatments, and so we are able to do re-radiation and in fact re-surgeries, as we talked about, which were earlier not possible. So because patients are living longer, so we definitely are seeing more recurrences. We are seeing patients with second primary tumors, we are seeing patients with oligometastasis, oligoprogression, and all these have totally changed the landscape of cancer treatments. Dr. Dinesh, do you think surgeons will ever be out because we are doing a lot of SBRTs, we are doing immunotherapy, targeted therapy? So do you think that surgeons, anything can replace surgery? Wrong question to ask a surgeon,
Yes.
but still I want your answer.
So I hope that shouldn't be that scenario doesn't occur any day. But I don't think so, because like you told, most of the cancers nowadays, we know that when they come early, surgery might be the only treatment. And as such, we don't have any issues with the people coming for surgery, but many people miss out on chemotherapy. So radiotherapy also is not a problem here. Surgery, they come, but chemotherapy, somehow they don't accept for chemotherapy. Main thing is they know that they will have hair fall and other side effects. So which has to be counseled properly. I don't think so. We are missing anything for surgery, and I don't think so. surgeon will be out-fashioned for cancers at least.
Yeah, I'm glad to hear that. So all of us have to work in unison, then only we can make lives better of these patients. Next slide, please. I think that would be my last slide because we have other sessions also. Smriti, my next slide, please. So I think some solutions are that knowledge conquers cancer. So we have to have more knowledge, we have to read more, we have to understand the interplay of different modalities. Like as a radiation oncologist, I must know how does a surgeon play with this knife and understand the natural history of the diseases, and then understand which patient would need neoadjuvant treatment, which patient would need neoadjuvant chemotherapy, and then proceed further. We have to educate people about cancer, and more work has to be done on prevention and early detection of cancers. We have to provide more healthcare budget for cancer control. We have to create more healthcare facilities and state-of-the-art facilities in every city. And I think this is very, very important, that we have to make the treatment affordable and easily accessible to every patient everywhere. And it's very, very important to provide evidence-based, ethical, high-quality cancer care. Not just because I have the best of LINAC or we have the best of robotic facility, we should go and operate on the patient or give immunotherapy to every patient. We have to enroll more patients in clinical trials, including children and minority communities. So let's help turn science into a sign of relief for patients around the world, so that we have more and more of hits on cancer treatments across the globe in each and every nook and corner of the city, and we have less of misses. We don't cause any comorbidities to the patients because of treatment. Idiopathic toxicities should be minimized. Every patient should be discussed in the tumor board, and the patient should be the captain of the ship. We should lay down all the treatment plans across on the table, and then in a multidisciplinary team, the treatment should be decided for the patient so that we can give a good quality of life to each and every patient. Next slide, please. That's what I have to say from this side. This is my team, TrueBeam STX Narayana Super Speciality Hospital. Thank you so much for having me here. And I hand over the mic to our illustrious speaker, Dr. Anil D. Cruz. Thanks for having me here.